right, hello everyone. This is Dr. Pruett. Today we're going to be talking about ophthalmologic emergencies. I know these happen infrequently, but when they do, they can be a little grotesque. And don't worry, I have some good pictures for you today. When we're talking about eyes, we always, just like everything, start with anatomy. And so first thing to notice is the cornea, which is a very thin layer of epithelial cells, which is a type of skin cells that overlays the rest of the eye. Then you have the anterior chamber that's filled with fluid. Then moving on towards the back of the eye, we've got the iris, and this is the part of the eye that gives it its color. So blue eyes, green eyes, brown eyes, the iris has the pigment. And the iris is also what is contracted around the lens to allow light to penetrate to the back of the eye. So it goes through this vitreous chamber that has vitreous humor in it to hit the retina, which then an image is conveyed through the optic nerve to the brain where the image can be interpreted, and that's how you see. Just like any major organ, the eye has a significant amount of blood supply, including arteries and veins, and then there's also nerve supply. So it's often been said that the eyes are the key to the soul, the window to the soul, and that's because they directly connect to the brain here by these optic nerves. And there's many different nerves that dictate eye movement and vision. There's different muscles of the eye too, move it up, down, left, right, sideways, very complicated. And each one of them has different innervation as well. So the way that the eye moves, you can tell a lot by the way the eye moves and trying to find where a problem might be. Looking at the anatomy of the face, there's also many different bony structures that surround the eye, and this becomes an issue when you have a patient with ocular trauma, because depending where the break is, you're going to have different effects on the ability to move the eye, or maybe bleeding in the eye or nerve injury. We do have a guideline in the ABC AMS guidelines that refers to eye injuries, specifically trauma, because that's one of the more common things that we see. And today I'm going to review a lot of different complaints that can surround ocular issues. So when I'm taking a patient history and someone who's having problems with their eye, I ask if it's painful. This helps me think about different causes. And then how is the vision? Is it absent? Is it blurry? Is there double vision? Do they wear contacts or glasses? Any recent trauma to the eye, and is there any discharge from the eye? These are all important questions that should help lead you down different potential causes of what's going on with the eye. And really the thought in my head is this infectious? Is it traumatic? Or could this be an underlying medical cause of what's going on here? So when you're looking at the eye and you're trying to assess it, you want to just look at it externally. I always look, what does the white part of the eye look like? Is it white? Is it red? Is it draining? Does it look painful? Are they squinting? Are they able to open all the way? Is the eyelid swollen? Is there redness around the eye? How does the pupil look? Is it round? Does it react to light? Does it react equally with the other eye? Can the eye move in offward directions? Left, right, up, down? Does it move symmetrically with the other eye? How's the vision? Are you able to see light? Can you see two fingers? What color is my glove? Those kinds of things will help you figure out what's going on. One of the more common complaints, I don't know that people necessarily call 911 for this, but I don't doubt that they have before, is conjunctivitis. This is often called pink eye, and it's literally just a pink eye. And so what you'll see, it's usually painless. There's inflammation around the conjunctiva, so that's the white part around the eye. It's red and injected and typically watery. Sometimes you can have purulent discharge coming from the eye as well. This can be caused from allergies, can be caused from viruses, and also caused from bacteria. Very contagious if it is caused by a virus or bacteria. So if you have this patient, make sure you're wearing gloves and make sure you're washing your hands. If the eye is so goopy that it's essentially glued shut, you can use baby shampoo to remove the goop and then get a good look at the eye. Sometimes this is a little bit itchy too, so if they get the watery discharge on their hands, make sure they're washing their hands as well, and be careful with what they touch because it does spread pretty easily. Not necessarily an emergency, but it probably needs some drops to help it get better. Corneal abrasion is a little bit more serious. If you remember, the cornea is that epithelial lining over the eye. It's just a thin layer of cells, and sometimes this can get scratched. So this is actually very painful, causes a red and watery eye that's very sensitive to light, and it feels like there's something in it, and it's kind of scratching. So there is a risk for infection because remember, this is just a thin layer, and if that infection reaches beyond that first layer of epithelium, it can get into the eye itself and cause a lot of problems. So you want to catch these early. They're not subtle. The patient is typically squinting and in a lot of pain. Ask them about anything that might have gotten foreign debris in there. So like, were they in a dust storm recently? Do they wear contacts? Any welding or pieces of metal, or did anything get into the eye? And usually they'll give you a pretty good history for something. In the hospital, we stain this with fluorescein so you can look at it under a dark lamp and see where the scratch actually is. Here's a patient with a foreign body that's embedded in their eyelid that is literally scratching their cornea every time the eye moves and every time they blink. And so here's another look at what that ulcer might look like. Different types of eye infections. We did talk about a corneal abrasion leading to a possible infection. So here's an ulcer where it's actually gone a little deeper, and you can see this without even staining the eye. You see this white kind of scarred tissue here. That's a corneal ulcer that's reached a little bit past that epithelium. Typically this happens in contact lens wearers. It's very painful. They're squinting, they're watery, it hurts. This absolutely needs antibiotics, because if it's not treated early enough, that infection can get into the anterior chamber, and here you see it starts to become purulent as the body is reacting massively to this infection. You can see that the purulence is starting to collect in the bottom of that anterior chamber, and that's called a hypopion. Sometimes this can also signal an autoimmune disease, but more often than not it's due to infection, and this will be very painful. Your patient will definitely be photophobic and have a really watery, painful eye. So orbital cellulitis is another type of eye infection. Signs and symptoms of this are more outside of the eye rather than the eye itself. So you're going to see a red, swollen upper cheek and eyelid. It usually doesn't involve the white part of the eye, but it is going to be painful when the patient tries to move their eye. So you want to assess their ocular movements. A lot of times they'll have other systemic symptoms of infection too, so they might complain of fever. It can extend from sinusitis, so your sinuses are right below here, and if they're full of purulent material and infectious things, that can extend to the skin right here and then go around the eye. And here you see a picture, a CAT scan of orbital cellulitis, and you see how this left eye is much more, we call this proptotic, which really means it's moved forward compared to the right side. And that's signs and symptoms of this infection really causing a lot of problems for this patient here. If it's not treated and recognized early, that infection, just like we talked about, that eye is directly connected to the brain. So if you're getting infection in there around the eye, it can lead to meningitis, it can cause abscesses in the brain, and it can even cause blindness if there's too much pressure on that optic nerve for too long of a time. So these patients will typically get admitted to the hospital. Sometimes they need surgery, but sometimes they just need IV antibiotics, but this could be a eyesight-threatening emergency. Dacrocystitis is not that common, but can look pretty remarkable. It's basically blockage of one of the nasolacrimal ducts, and if it's blocked for too long, just like anything, can get infected. So it'll be red, painful, tender. The eye will be swollen around it, and it's right where that duct is located. I don't know, when I first learned this, I thought it was the coolest thing, but the way tears are made, they're made from this lacrimal gland, and then they wash across the eye until they're drained here into the nose. That's why when you cry, you get a runny nose, because your tears are coming from here, and they're flooding this duct here, and then it runs right into the nose and drains. But if that is blocked, obviously, then it's going to run out of the eye. Moving on to trauma, one of the most remarkable things that we see is an open globe, and this is a eyesight-threatening emergency. You need to probably take these to a trauma center where they can see a surgeon right away. Some of the clues that this might happen, you're going to see a teardrop-shaped pupil, so the pupil is going to be irregular, or they might either have a foreign body in there too. That's very obvious. And so what you want to do with this is recognize that their sight is in danger, get them to the hospital as quickly as possible. You want to decrease any sort of intraocular pressure. So you want to loosely bandage both eyes, no pressure directly on the eyeball itself. Shield it or protect it however you can. If there's a foreign body in there, you want to stabilize it as best you can. I've seen styrofoam cups used before, and those tend to be pretty effective. You want to elevate the head of the bed, make sure you're controlling pain. And one thing that we can really do to help these patients in the pre-hospital setting is to treat nausea. Because if they start to vomit, that's going to increase the intraocular pressure and increase the probability that some of those ocular contents are going to protrude through the open globe. And you want to cause as minimal trauma to the eye as you can. So really do your best to keep them from vomiting and keep them comfortable so that you're decreasing that intraocular pressure. Absolutely do not remove any foreign bodies that are located in the eye. Just stabilize them, bandage them, and get them to the hospital. We see a lot of patients that have orbital fractures. These are usually from assaults. When you're evaluating these patients, one of the most important things that you can do is look at their eye movements. Ask them to look up. When the face breaks, sometimes when, say, somebody's hit right here in the temple with a fist or directly to the eye, one of the weak spots in the orbit is the inferior orbital wall. And if this wall cracks open, what can happen is the muscle that is on the bottom part of the eye, the inferior rectus, can fall through that opening in the skull and become entrapped. And what happens is that eye, as the muscle is trapped, can no longer look upward because the muscle that pulls it down is actually trapped in the lower part of the orbit. And you can see it here on this CAT scan. There's an orbital wall fracture. That's the white bone right there. And you can see the discontinuity in the bone. And the muscle is actually trapped below it, and that's an eye that can't move. And so that's probably going to need a surgery to correct it. Sometimes along with the immobility of the eye, the patients, like we mentioned, there's a lot of nerves around the eye too, so they might complain of facial numbness. Or you might even notice from the side that the eye might be sunken into the orbit a little bit more than the opposite eye. Again, with facial trauma, one of the things we think about is retro-orbital hematoma. This is an emergency that we have to immediately address in the trauma bay if we suspect that it's happening. And what's going on here is remember there's a large amount of blood supply to the eye. And depending on where that vessel breaks, if it makes a big enough area of bleeding behind the eye, it pushes the eye forward. And as the eye pushes forward, the only place that the blood can collect is behind that orbit. It pushes the optic nerve and compresses the optic nerve to where essentially you have compartment syndrome of the eye. And if that nerve is compressed for long enough, the patient's going to lose their vision. And so what we have to do in the hospital is release the tension on that eye, give the patient a place to bleed, and release that blood from the posterior chamber so that the optic nerve can be restored to normal. You want to catch it as quickly as possible. This patient will usually have an eye that looks like it's moved forward. If you look closely, they're going to have a lot of blood around the side of it, maybe not necessarily involving the sclera itself. You might see a dilated and unreactive pupil. That's a sign that there's a problem with the optic nerve, and you need to act fast. In the field, there's not a lot we can do other than recognize it and have a high degree of suspicion and move quickly to get them to the hospital. This is opposed to a subconjunctival hemorrhage, which is fairly common and also very benign. It's where a small capillary has ruptured and can be pretty remarkable when you see it. It's bright red blood just underneath that sclera there, and it can be caused by coughing or sneezing, maybe straining too much. Sometimes patients that have been vomiting really hard can break those blood vessels as well. People who are more prone to it are patients obviously on anticoagulants, but really this is not an eyesight-threatening emergency and will usually resolve on its own, as opposed to a traumatic hyphema, where there's actually blood collecting in the anterior chamber of the eye. If you see this is called a 8-ball here, where the whole anterior chamber is full of blood. Here you can see just the blood level in the anterior chamber here. These are patients, if you see them, you don't want to give them anything else that's going to make them bleed, so make sure you're avoiding NSAIDs. It's not necessarily painful. You want to keep them upright and get them to a hospital that has an eye doctor that can address this pretty quickly. Moving on to other types of foreign bodies that get into the eye, patients can receive chemical burns. And we all learned this in chemistry class when we were in high school and in college. Just make sure the answer to this is copious irrigation, and you want to start it as early as possible. So you get there, you ask exactly what was in the eye, whether it's acid or alkali. The answer is usually just give copious amounts of normal saline, use a couple liters if you need to, and get them to the hospital as quickly as you can. You can see here that this one has already burned off the cornea here. That first layer of epithelium is already gone. And you can start to see some ulceration on this one as well, that white cloudiness, and then the scleral injection around it. So lots of water, that's always a solution for these chemical burns to the eyes. Superglue is becoming a more common injury to the eye. Sometimes this happens in kids. Sometimes people with bad vision get the superglue mixed up with their eye drops. If this happens, you want to just use warm water and gauze over the eye. If the eye is glued shut, don't try to open it. Just try to provide for their comfort and put that warm water and gauze over the eye. They will need to be evaluated for underlying corneal abrasion, but usually once the glue comes off, patients do fine with this. We also, unfortunately, frequently see patients who have received OC spray or mace or pepper spray into their eye. Again, just like any chemical burn, you want to do copious irrigation until the patient feels better and eyesight and is restored and the burning has stopped. One unique thing we see here in the high desert, it's not necessarily unique to us, but we do tend to see it more frequently, is UV keratitis. This can be common in ski season too, but basically it's just where eyes are prolonged exposure to UV light can literally burn the eye. So this will be very painful. Patients will have tearing, they'll be very sensitive to light, and they will have a foreign body sensation. And sometimes it'll show up about 6 to 12 hours after the UV exposure. This can be from something as simple as sun tanning in a tanning bed, can be caused by welding, prolonged skiing, prolonged times in the desert or out in the sun without eye protection. This is what it looks like under a fluorescein stain. You can see there's just diffuse areas of burning, and I imagine it's very, very painful. Pterygium is something that we see frequently also in the desert. This is just caused by chronic exposure to UV light, not necessarily a massive amount of acute exposure. Tend to see it more in elderly patients, and this is where just the skin over the eye in response to the chronic exposure starts to grow thicker to protect the eye, and it tends to extend from the nasal edge of the eye towards the edge of the iris and is kind of a triangular or pyramid shape. Really benign, nothing to worry about with it. It just denotes that someone's been out in the sun too long or too much. Acute angle closure glaucoma. This is a very painful condition that causes headaches, frequently vomiting, and can easily mimic a stroke. Just a side note here, if you do worry that your patient is having a stroke or a head bleed, go ahead and treat them as a stroke or a head bleed, but realize that it could be acute angle closure glaucoma too. What happens here is this is just usually an older eye that has trouble draining fluid, and when they typically come into a dark room, as the eye tries to dilate and adjust to the change in the lighting, as the eye dilates and that iris moves, it cuts off the flow of the aqueous humor, and what happens is pressure tends to build up in the eye, and it's very painful. It dilates the pupil, it causes it to be watery, it can cause a headache, even sometimes vomiting. It does mimic a stroke because your pupils would be different sizes and typically unresponsive as well. Sometimes medications can precipitate this, but it's really just a fluid drainage problem based on the angles in the eye. And one other thing to think about, just like any organ that has a blood supply, vessels can either become clotted off or they can burst. And so a type of stroke that involves the vessels that lead to the eye is called Amaurosis Fugax. And this you'll probably more commonly see in your patients with atrial fibrillation, as clots are launched into the rest of the body and they start to find the smallest vessel that they can get to. Sometimes they go into the ophthalmic artery, and this can cause vision loss as the blood flow is cut off to the rest of the eye. Just like any stroke, blood flow will need to be restored, but you'll have a patient who complains of painless unilateral vision loss, and this might be their only symptom. So if you have a patient who you think has all the risk factors for stroke and is complaining of vision loss, this is one thing to possibly think about. Retinal detachment happens very frequently too. This is another type of painless unilateral vision loss, and usually your patient will describe kind of a curtain falling sensation, or they'll start to see floaters in their eyes or maybe flashing light. And that's where the retina, which is attached to the back part of the eye, for whatever reason becomes weak and just falls off, and that's that curtain that the patient starts to perceive is coming down over their eye, and it's a wave of darkness. And when you look at it on ultrasound, you can see the retina actually, here's the posterior part of the eye here, the retina is actually literally come off the back. And so sometimes that needs a surgery to repair it. You need to get them to the ER and they'll see the ophthalmologist to see if it needs to be repaired. So in conclusion, there's different types of eye emergencies, some caused by infection, some caused by trauma, some caused by chemical burns, and then there's medical causes too. So make sure you're always considering stroke in your patients who have painless vision loss. And really the only thing we can do about these are the ones with traumatic injuries. And if they have a foreign body or you're worried about that, make sure you're stabilizing the foreign body, you're protecting the eye as best you can, and you're treating pain and preventing nausea. And then make sure for those chemical burns you're irrigating as copiously as you can. And that's all I have for you. If you have any questions, please feel free to reach out to me or talk to your 7-8.